I'm going to be talking about some things today. The main focus on these slides and the discussion is going to be for liver involvement, although many of these things can be used for cancers outside the liver as well. But the topic is going to be pretty much focused on things that are happening in terms of surgical approach and options that we have for liver involvement. The fascinating thing to me is most of what I'm going to be talking about was not available when I finished training. So I guess that goes to the point of saying this concept is about hope, about what the future offers. And most of what I'm going to be talking about today, when I finished my surgical training and went out and began my practice, the therapies that we're talking about have been things that have come along since that training. So we are always in the process of learning as well, and looking and searching for and discovering and training in new technologies that demonstrate a real benefit. So it's really kind of an exciting time and an exciting process. So new advances in surgical treatment of liver tumors. Some of these slides I'm going to quickly go by, but first some just concepts. Primary, so these are kinds of disclaimers about what is out there in terms of standard thought process. There are a lot of people who think involvement of the liver with disease suddenly means that there's no effective therapy that will be available, and that's just not true. Primary and metastatic tumors are very treatable. The myth that they are not is simply a myth. Tumors in the liver are very treatable. Resection, local ablation, and embolic therapies exist to a high degree of expertise right in this community. The people at this table represent some of the most experienced people in the nation and internationally in some of these therapies. Right here in Denver, we have the great option, I have the great option, of working with incredibly experienced and talented people. Lastly, service line multi-specialty team collaboration has been developed for the best treatment selection. Selecting cancer treatments in each of our own subspecialties is important, what new advances are there. But the secondary part that's incredibly important is to organize as teams with a good communication in terms of what's the right sequence for a particular person. Do we do surgery first? Do we do chemotherapy first? When we're observing over time, what are the options that we have? And who's the right therapist at the right time, and which of those therapies is appropriate? Makes a huge difference in how we respond to our patient and how the cancer responds over time. When I think of things in the liver, I kind of go through an algorithm in my own mind to kind of think about what are the options and possibilities available. So it's first just what options are theoretically possible. I wonder about whether the disease we're talking about is multiple sites or single, whether or not one side or both sides are involved. Is resection even a possibility? One of the daunting figures and statistics we face as surgeons, 80% of tumors in the liver cannot be initially considered resectable. 80%. Only 20% are surgically able to be approached initially. So we have to create opportunity, and we've developed opportunities for treating the cancers where they live, with either then creating an opportunity for resection or killing the tumor so that resection is something that we don't need to consider. So anatomy is important. Number of lesions also makes a difference in what selection process. Is there 1, 2, 3, 4, 8, too numerous to count? That will depend on the therapies that we're going to think about. What's the treatment history? We've heard about different kinds of therapy that can be undertaken. That makes a difference. What's happened before, and does that open up or does it limit some of the options that we might have surgically? And lastly, the cellular origin of the tumor and how it has a tendency to be responding. I think about the cancer therapy and local therapy, therapies that are regional or therapies that are systemic. I'm a local therapist. I attack something locally, I remove something physically in a particular location. So I'm a local therapist. Dr. Nutting is a regional therapist and a local therapist. He can treat the entire liver. He can treat a particular spot. Dr. Hinja is a systemic therapist. So we combine these things to address all aspects in terms of our approach. All kinds of things we can do with surgery, and all things that have become available since the time that I trained. Systemic therapies, etc. For the local therapies, we have a lot of different ways to approach all of this. We have resections, we have local destruction, high heat local destruction, laparoscopy that we can use in these technologies, and a brand new technology that uses a completely different approach, an electrical shock kind of a therapy to deliver a lethal injury. It's called Nano Knife. I'm a surgeon. I have surgical pictures. So this is a liver. This is just an example of a very large tumor in the lobe. A lot of people would look at that and say that's just not something you can treat. And the fact of the matter is, resections have never been safer. So anybody who is a card-carrying liver surgeon in the year 2014 really understands that we've made tremendous strides forward in safety for our patients. So we can take on and do major resections and limited resections in combination and repeatedly with extremely high safety and minimal complications for our patients. A lot of different kinds of technology that we use to make things a lot safer. This is current day. Usually the transfusion we're requiring for major liver resection is no transfusion. So we have such good control of the environment that we're not having instability, there's not a lot of blood loss, and we rarely have to use a blood transfusion. 80% of tumors, I don't have an option to be able to cut them out, either because of their location and anatomically or because their lesions are too numerous. If the lesion is in a bad location, we had to find something to solve 80% of patients who can't have their tumors removed. So those started with alcohol ablation. That's just high concentration alcohol. Very effective, kind of difficult to use because it's not very specific, kind of wants to go where it wants to go once delivered. Quickly shifted to cryoablation technology. Excellent technology using liquid nitrogen, freezing a tumor and having it die. Highly effective. It was actually one of the most highly effective non-resection local killing techniques we used. The problem is, I don't know how many of you have ever worked with liquid nitrogen. It's very scary stuff. It hisses and pops, and it was kind of like sci-fi in the operating room, and just not a big comfort level, okay? That quickly changed, and we went to the opposite direction to create really high heat. That's radiofrequency ablation, much better. Electrically based, we're very comfortable with electricity in the operating room. Needle driven, so we could do it open, we could do it laparoscopic, we can do it percutaneously with our interventional radiologists, creating high heat to destroy everything that came into contact with that heat. The great part about it is highly effective. The limitations, blood vessels, and if the structure that we were treating had ducts, we would disrupt the ducts and end up with a catastrophic mess. So there were some limitations to its use, but highly effective and still a very, very, very effective tool, and we use it very frequently. Lastly, Nano Knife. That's brand new. It's about 5 years old. Nano Knife addresses the limitations that we have for destruction with high heat in structures with ducts. If I have a cancer of a bile duct, I can't use high heat because I'm going to destroy the duct and I'm going to end up with an oozy, leaking mess. I can't use high heat in the pancreas because, again, ductal structure, I'm going to have a catastrophic leak as I damage the ducts. Nano Knife is an electrical shock therapy. It does not generate high heat. It induces a lethal injury to cellular populations. So the tumor dies, but the connective tissue structures do not. Pretty fascinating. Radiofrequency ablation, highly effective. We talked about it. Currently can be used percutaneously by our interventional radiologists. Due to location and size, Dr. Nutting and I are in very close communication. He's on my phone, I'm on his phone. We will call each other throughout the day sometimes and communicate. I think I have someone I've seen in the office. I think they're going to be better to be done laparoscopic or surgically. Gee, I have someone I've seen, and I think, Charlie, this can be, someone who would be well treated by a percutaneous route. So once again, interdepartmental cross-referencing team function is a huge part of successful therapy. This is what a radiofrequency probe looks like. The tines come out so you can adjust how big of an area you're going to be killing. Highly effective, very safe, and has been quite frankly used for probably the last 15, 20 years perhaps. Hundreds and thousands of patients have been treated with really high effectiveness and very high safety. That's a tumor. This is the liver. This is the needle engaging and treating different areas. We can do it laparoscopic, so in the operating room now, camera is going to be our eye. There's a tumor here. I can use ultrasound. I can guide the needle by seeing it on ultrasound. A little hard to see, but this is the area that we're destroying underneath the liver, observed by ultrasound, making sure the needle is engaged and delivering a high heat ablation. Okay. Just pictures of before and after the area of ablation. Tumor destroyed plus a margin clear around it. Electroporation ablation, this is Nano Knife. This is the technology that's been around for decades and decades and decades. Our cell biologists have been using it as a research tool. By simple observation many years ago, an observation was seen. You pass an electrical current through cells. The effect of that is pores or defects form in the cell membrane. Below a certain threshold, the cell can heal that injury. So our cell biologists have been using it as a workhorse. Create the injury, now I can study how a cell heals itself. If you go a little higher in that electrical charge, the pores form, but they cannot be repaired, and the cell goes through an automatic shutdown to death. We call that apoptosis. Now we have a research model to study how a cell shuts itself down. An oncologist talking with his cell biologist friend, talking about this wonderful technique of having a way to induce a lethal injury to cells, and the medical oncologist said, "Did you ever think of killing cancer with that?" "No." "Well, I guess you could." That's Nano Knife. So it's taking this decades-old technology of electroporation and bringing it into the operating theater and percutaneously in interventional radiology to engage, place needles, and create an electrical shock therapy through the tumor that delivers a lethal injury. Huge for those organs that have ductal structures, because I don't disrupt the duct, I don't disrupt blood vessels, but we kill the tumor. Highly effective in the liver. We can use it in the kidney. We can use it in the pancreas. Connective tissue structures, again, are not affected. So it's ideal for many things in the liver where there are big blood vessels, or if the tumor is around and close to the bile duct, so I can't use radiofrequency ablation because I don't want to damage the duct. I can switch and I can change my thought process using the same technology laparoscopically or open or percutaneously and deliver an electrical shock injury. Kill the tumor without damaging the duct. These are just some description kinds of signs. These are the spectrums. So if we have an electrical shock in here, nothing happens. Here, irreversible. If we go too high, we're going to end up thermal. I don't want to be here. This is the sweet spot of where we want to be in terms of our delivery of an electrical energy. That's the zone that we know is going to be created around the needles. That's the area that will be irreversibly injured. That's the damage in study circumstances. This is supposed to demonstrate that I could treat a tumor and I'm not going to damage the blood vessel that passed through there. It's delivered in sequences. Here are the needles. I need 2 needles to have an electrical current. If I want to treat a bigger volume, I just put in more needles and the machine will pick each pair and deliver the shock in the appropriate time and sequence. That's the needle. This is in the active treatment of a tumor. 1, 2, 3, 4 needles placed. A combination of treatment across all pairs ends up with a treated area. This is in the operating room. This is a pancreatic cancer that we were treating that was unresectable and we were able to treat very effectively. Can be used in liver diseases. Laparoscopy, basically it's just taking everything that we just talked about open and doing it with a non-invasive technique in the operating room. This is becoming more and more important to think about. Minimally invasive surgery. Remember, we're having patients who go through sequence of therapy more and more commonly. If I can do a very, very good and succinct procedure and yet have my patient recover in a faster time frame, I have injured them less. One of the things that we know is that the more I injure you as a surgeon and the longer your recovery, the more your immune system is damaged, and your immune system is very important in terms of being able to be an active part of your fight against cancer. If I can accomplish the very same endpoint laparoscopic that I can open, I'm helping because I damage you less, you have less of a recovery, your immune system is weakened less, you get to subsequent therapy faster, and your immune system is stronger. So laparoscopy is and will continue to play an increasing role in the options that we have. Currently, all of the options that we talked about in open can be done laparoscopic in my hands. Not everyone is a laparoscopic candidate. Many people are. That's part of that whole decision-making process. So current model is team management with patient presentation and treatment management selection. I think this is one of the most important things that we do currently. We've been doing it in this community for 15 years, so we're ahead of the curve. We understood the importance of talking with each other, sequencing, direct communication. I'll go first. In this particular case, no, you go first, I will follow. And then over time, as we watch patients who go from no evidence of disease to new evidence of disease, it's important to sit down as a team and then be able to say, what are the options that we have, whose turn is it to go, and what are we doing? So we can do that to a very high degree, and I have the privilege of working with incredibly talented people in this community. Thank you.